Today we're diving into one of the most critical concepts in nursing and medicine: shock. Understanding shock is essential because it can affect any patient in any setting, and early recognition can be the difference between survival and decline. What is shock? Shock is a clinical syndrome that happens when the body's tissues don't get enough blood flow. That means oxygen and nutrients can't be delivered at the rate needed to keep cells alive and functioning. Three components have to work properly to maintain perfusion: an effective cardiac pump, a healthy vascular system, adequate blood volume. If even one of those is impaired, perfusion is threatened. Without treatment, this leads to cellular hypoxia, organ dysfunction, and eventually death. Shock doesn't discriminate. It can come on suddenly or gradually, and every body system gets involved. The body tries to fight back through compensatory mechanisms, but if those fail, shock spirals into a downward cycle. Normal cellular function. Let's take a step back. Under normal conditions, cells use oxygen to produce energy in the form of adenosine triphosphate, or ATP. This is called aerobic metabolism, and it's efficient. But in shock, oxygen delivery drops. Cells are forced into anaerobic metabolism, which produces less ATP and leaves behind lactic acid. That lactic acid builds up, creating an acidic environment that damages cells. The cell membrane becomes leaky. Electrolytes shift, mitochondria get injured, and eventually the cell dies. At the same time, stress hormones like epinephrine, cortisol, and glucagon are released. These cause hyperglycemia and insulin resistance. The body breaks down proteins and fats for energy, depleting stores and worsening organ function. On top of that, the clotting cascade is triggered. Tiny clots form in the microcirculation, further limiting blood flow. It's a vicious cycle. Vascular responses and blood pressure regulation. The vascular system tries to adapt through autoregulation. Local signals tell vessels when to dilate or constrict, depending on oxygen and nutrient needs. Cytokines play a huge role here. These are chemical messengers released by immune cells. They can cause either pro-inflammatory or anti-inflammatory effects. Blood pressure regulation is key. It depends on three things: blood volume, cardiac output, vascular tone. The formula we use is mean arterial pressure equals cardiac output multiplied by peripheral resistance. Mean arterial pressure, or MAP, needs to be at least 65 millimeters of mercury to sustain organ perfusion. Baroreceptors in the carotid sinus and aortic arch sense pressure changes. They activate the sympathetic nervous system, releasing catecholamines like epinephrine and norepinephrine. These raise the heart rate and cause vasoconstriction. If that's not enough, the renin-angiotensin-aldosterone system kicks in, leading to vasoconstriction and fluid retention. Antidiuretic hormone, or ADH, from the pituitary gland also helps the body hang on to water. These mechanisms can respond quickly, but they can't hold out forever. Stages of shock. Shock progresses along a continuum. We break it into 3 stages. Stage 1, compensatory. Blood pressure looks normal, but the body is fighting hard. Vasoconstriction, tachycardia, and increased contractility help maintain cardiac output. Blood is shunted away from the skin, kidneys, and GI tract toward the brain, heart, and lungs. Patients may have cool, pale skin, decreased urine output, and hypoactive bowel sounds. Mental changes like anxiety or confusion may appear. Metabolic acidosis develops from lactic acid buildup, but the respiratory rate increases to blow off carbon dioxide. This can sometimes cause respiratory alkalosis. If shock is recognized here, prognosis is much better. Stage 2, progressive. Compensatory mechanisms fail. Mean arterial pressure falls below 65 millimeters of mercury. Hypotension develops with systolic blood pressure 100 millimeters of mercury or less, or a drop of 40 millimeters of mercury from baseline. Mental status worsens: agitation, delirium, lethargy. Organs begin to decompensate. System effects include lungs, rapid shallow respirations, crackles, pulmonary edema, risk for acute respiratory distress syndrome. Heart, arrhythmias, chest pain, possible myocardial infarction, troponin elevation. Brain, confusion progressing to unconsciousness. Kidneys, decreased urine output, rising BUN and creatinine, acute kidney injury. Liver, impaired metabolism, elevated enzymes, jaundice. Gastrointestinal system, ulcers, bleeding, bacterial translocation. Hematologic system, clotting cascade dysfunction, risk of disseminated intravascular coagulation. This is a critical turning point. The longer tissue perfusion is inadequate, the lower the chance of survival. Stage 3, irreversible. Organ damage is severe and unresponsive to treatment. Blood pressure remains low despite support. Anaerobic metabolism is widespread with severe lactic acidosis. Multiple organ dysfunction occurs: renal failure, liver failure, cardiovascular collapse, and respiratory failure. Death is imminent. At this stage, care focuses on comfort and supporting the family. Medical and nursing management. Management depends on the type of shock: hypovolemic, cardiogenic, distributive, or obstructive, but general strategies apply across the board. Medical management includes oxygen therapy and ventilatory support, intravenous fluids to optimize intravascular volume, medications to support heart function and vascular tone, careful glycemic control, keep blood glucose under 180 milligrams per deciliter, nutrition support and gastrointestinal protection with antacids or H2 blockers. Nursing management includes continuous assessment for early, subtle signs, changes in mentation, urine output, pulse pressure, skin color, and lactic acid levels, monitoring hemodynamics, vital signs, labs, and invasive monitoring when present. Reporting drops in systolic blood pressure at or below 100 millimeters of mercury, a mean arterial pressure at or below 65 millimeters of mercury, or a systolic drop of 40 millimeters of mercury from baseline. Preventing complications like infection, ventilator-associated pneumonia, and delirium. Promoting comfort by clustering care, managing pain, decreasing anxiety, and encouraging family presence. Advocating for discussions about advanced directives and end-of-life preferences. Reducing anxiety and supporting families. Shock isn't just a physiologic crisis, it's an emotional one. Patients and families often feel intense anxiety. Nurses play a vital role by explaining what's happening in clear, calm language, providing reassurance and gentle touch, supporting family presence during care, encouraging communication and shared decision-making. When shock becomes irreversible, care shifts to comfort, dignity, and family support. Palliative care and honest conversations become essential. Final takeaway: shock is a life-threatening continuum. Early recognition, aggressive intervention, and compassionate nursing care save lives. Remember the hallmarks. Watch for subtle signs before blood pressure drops. A mean arterial pressure under 65 millimeters of mercury means organs are at risk. Every stage has distinct clinical features. Know them well. And never underestimate the power of patient and family-centered care in these critical moments.